Meet Kim. Kim is a 37-year-old diabetic female who came to the hospital presenting with high blood pressure, fatigue, and swollen ankles. Due to her high blood pressure and diabetic history, Dr. Allen is concerned for her kidney function, as these are the most common causes of kidney failure. He orders blood and urine tests, and the high levels of creatine in her urine confirm that Kim is in kidney failure. The kidneys are two bean-shaped organs, and since Kim is in kidney failure, she has lost the ability to filter and remove waste from the body by producing urine, the main function of the kidneys. Dr. Allen starts Kim on dialysis as she is added to the kidney transplant list to receive an organ from a deceased donor. Dr. Allen completes Kim's transplant, and she remains in the hospital as her medical team monitors her creatine levels. Her team starts her on immunosuppressant drugs such as corticosteroids and calcineurin inhibitors. After 5 months with her new kidney, Dr. Allen confirms she is now rejecting the kidney. Nearly 30% of people who receive a kidney transplant experience some degree of rejection. This reaction is based on antibodies binding to MHC or HLA complexes that do not match each other. Kidney rejection typically occurs via T-cell mediated rejection or antibody rejection.
The parts of the immune system that are involved in Kim's rejection are the innate and adaptive immune systems. The innate system is what Kim was born with and is encoded into her germline and has low flexibility. It protects her body from infection. Important cells in the innate system include macrophages, neutrophils, and natural killer cells. Macrophages are a type of white blood cell that signal for inflammation and destroy pathogens through phagocytosis. Neutrophils are also a type of white blood cell that do phagocytosis, but also do extracellular killing through degranulation and netosis. Natural killer cells can secrete cytokines that strengthen macrophage responses, and they can trigger apoptosis in infected cells. These cells are all at work after Kim's transplantation surgery and are fighting against the foreign body. The adaptive immune system includes B and T cells. B cells produce B cell receptors and antibodies that can bind to extracellular microbes and break them down. B cells' DNA goes through a series of rearrangements in order to have an affinity for microbes and are activated when the B cell receptor binds to an antigen on a microbe. After activation, B cells can differentiate into plasma cells, which produce antibodies, and memory cells, which can remember pathogens for when they are encountered later. The antibodies can then migrate to sites of infection and begin targeting pathogenic cells. T cells are the other part of the adaptive immune system. T cells themselves fight against pathogens at the site of infection. T cells come in the form of helper T cells, which work in the activation of inflammation and of macrophages, as cytotoxic T cells, which directly kill pathogens, and as regulatory T cells, which regulate the immune response. T cells are activated by binding to a major histocompatibility complex, which presents antigens from the invading pathogen. If a T cell has some affinity for the MHC and its antigen, then it is activated and can go to the site of infection to perform its functions. The innate and adaptive immune system must be controlled with immunosuppressant drugs, or they will cause the rejection of an organ. As soon as Kim's new kidney is in her body, her immune system starts working to recognize the allograft. The initial inflammatory response is due to ischemia reperfusion injury. This injury occurs when blood supply returns to the body after a period of low oxygen. This injury is detected when pathogen-associated molecular patterns, or PAMPs, bind to pattern recognition receptors, or PRRs. PAMPs are components of a pathogen, or in this case, foreign body, that your immune system does not recognize. PAMPs bind to PRRs to signal to the immune system that there is an intruder in the body. Toll-like receptors are a type of PRR that are vital to allograft inflammation and acute and chronic rejection. After PAMPs and PRRs have signaled that there is non-self in the body, the transcription factor NF-kappa B is activated and regulates pro-inflammatory cytokines and the inflammatory response. These cytokines are able to bind to innate immune cell receptors and trigger their response to the foreign body. Macrophages use reactive oxygen species and phagocytosis to kill and reject allogenic non-self cells. Neutrophils are recruited to the graft and allow effector and memory T cells to get into the graft and become antigen-presenting cells. Natural killer cells can bind to ligands on infected cells and trigger apoptosis. Natural killer cells contribute to rejection by recognizing allogenic cells through unique receptors that identify missing cell pieces. Dendritic cells are immune cells that present antigens on their surface. They are activated by PAMPs binding to PRRs and can then act as antigen-presenting cells to activate T cells. The complement system is another important innate immune system that is involved in Kim's kidney rejection. The classical complement pathway is activated by the binding between antigens and antibodies. This ultimately leads to opsonization and phagocytosis and the formation of the membrane attack complex, which results in injury to the allograft cells. The activation of the classical complement pathway is the start of antibody-mediated rejection. The innate immune response can also cause tissue damage without the complement pathway. Antibody cell-dependent cytotoxicity occurs when the natural killer cells and macrophages are activated via Fc receptor interactions.
Antibody-mediated rejection is reliant upon B-cell responses. This is a result of the classical complement pathway being activated. The C3a and C5a molecules are byproducts of this pathway and serve as chemokines to enhance inflammation. Antibodies attack donor-specific MHC molecules that cause this type of rejection. One way to diagnose if Kim is experiencing antibody-mediated rejection is to do a C4D stain. C4D is another byproduct formed during the classical complement pathway. If this kidney is undergoing rejection, high levels of C4D will be found in the peritubular capillaries of the donor kidney. This is abnormal. Another indicative assay can quantify the number of anti-HLA antigens to antibody complexes formed. Combined, these tests show that the patient has acute antibody-mediated rejection. To treat this, the donor-specific antibodies are reduced via the removal of host B cells and plasma cells. B cells create antibodies that fight infections and extracellular microbes. They play an important role in allograft rejection. B cells produce high-affinity antibodies against the new organ that cause rejection. These are referred to as donor-specific antibodies and anti-HLA alloantibodies. Alloantibodies are only produced when the body is exposed to foreign red blood cell antibodies. B cells can also act as antigen-presenting cells and can activate T cells. Antigen-presenting cells present antigens on MHC molecules, which T cells bind to in order to be activated. B cells present MHC class II molecules, which can bind to CD4 positive T cells and respond to foreign organs as helper T cells. T cells can identify the foreign organ via direct, indirect, and semi-direct allo recognition. Direct recognition is when the donor-derived antigen-presenting cells present MHCs to T cells. Indirect recognition is when Kim's antigen-presenting cells take up foreign peptides and present them on MHCs. Semi-direct recognition is when recipient antigen-presenting cells present both whole MHC complexes from the donor and peptides on self-MHC complexes. B cells are the contributing factor to antibody-mediated rejection and is what is causing Kim to reject her organ. There is also a chance that Kim is experiencing acute T-cell-mediated rejection. If this is occurring, then her transplant has ongoing tissue damage caused by T cells and their activated macrophages. High levels of interferon gamma, which is an activating cytokine, and transforming growth factor beta, which is associated with the repair of renal tissues and found in high levels during kidney disease/rejection. The T cells and macrophages can cause inflammation and tissue damage once they extravasate into the renal tissue. However, the first wave of T-cell-mediated rejection is thought to be carried out via specialized peripheral surveillance memory T cells, which circulate the body tissues all of the time. The donor kidney will react to the injury, and nephrons will no longer undergo normal activity. They will instead focus on repair. This injury response results in inflammation, and more T cells will follow a chemokine gradient. The CD4 positive T cells involved in this reaction are predominantly TFH effector cells, which assist in the activation and differentiation of B cells with high affinity for the donor antigens. Interferon gamma, which is produced by activated T cells, induces the expression of previously mentioned cytokines and MHC molecules. It can also bypass the antigen presentation that is normally required to activate T cells. This enables T cell-mediated rejection to occur in patients with low T cell levels and makes it more difficult to suppress these immune reactions. CD8 positive cytotoxic T cells are typically unable to kill the endothelium cells present in the renal tissue despite the presentation of MHC antigens. Instead, cell death occurs via dedifferentiation. It means the cells will regress and die off. Most cell death will occur in small pockets around the original activated T cells. In order for Kim to recover from T cell-mediated rejection, she will need to undergo additional corticosteroid treatment and T cell depletion.
Kim ultimately rejects the kidney donation and requires a new transplant.